Okay, so it is 8 o'clock, so I will start us off. So good morning, everyone. As we enter June, today is the last Chief Resident Grand Rounds presentation of the year, and I have the pleasure of introducing Dr. Lindsay Matthews as our Grand Rounds speaker. Dr. Matthews completed her undergraduate degree in anthropology and human biology at Emory University before completing her MD training at Tulane. Lindsay completed, as you know, her internal medicine residency training here at UW, where she has excelled as a clinician, educator, researcher, and leader. Lindsay's been an active collaborator with several researchers in the Division of Gastroenterology, including Dr. Saha and Lucy, with published works on electronic messaging among IBD patients and psychosocial evaluation in liver transplantation. Lindsay has been the recipient of numerous awards during her time here at UW, including first place in the David Whistler Memorial Research Competition for Clinical Research and the Residency's Wellness Promotion Award, among many others. Lindsay will be continuing on in the next academic year as a hospitalist here at UW and is applying for a gastroenterology fellowship this fall. Lindsay has been an exceptional chief resident and an invaluable member of our residency community for the last 4 years. She's a gifted teacher and educator, a thoughtful advocate, and an outstanding colleague and mentor to many within the department and the residency. As with all of our chief residents this year, the residency and the department are far better places for her efforts, attention, and kindness, and we are incredibly proud to count Lindsay among the graduates of this program. Today, Dr. Matthews will speak about psychosocial evaluation in the liver transplantation process. Please join me in welcoming Dr. Matthews.
All right, well, thank you so much for the introduction, Andy, and thank you everyone for tuning in this morning. I have to say, it's pretty surreal that my chief year is coming to an end. And like Andy said, I'm the last one of the 4 chiefs to be presenting at Grand Round. So really, it is such an honor for me to be here speaking with you all. So today I will be talking about psychosocial assessment in liver transplantation. And I couldn't help myself, I had to add in a little pun. So we will be distilling the 6-month rule today. So I'm excited to be talking about this topic. I still remember when I was an intern, one of my first months was on the general medicine service, and we had a patient with acute alcohol-associated hepatitis. He was extremely ill. And he was hospitalized for quite a while, so I got to meet his wife and his 2 kids. But he was so ill that every single morning when I opened up the electronic medical record, I dreaded seeing if his name had fallen off of our list, because we all knew his only chance at getting better was to get a liver transplant. So every day, our team would anxiously await to hear if he would be a candidate or not. And I just remember having this feeling like kind of so much was out of our hands and so much rested on the decision if he could be listed or not. And it wasn't until the next year, my 2nd year in residency, that I got the chance to rotate on the hepatology service and learn a little bit more about what went into that decision. So hopefully we can all get a little bit of a peek behind the curtain today and help to demystify some of that process. So I want to start by just taking a step back and kind of framing this whole talk and the issue of liver transplantation more broadly. So I think we all kind of have an idea that liver disease is common, but it can be helpful to put some numbers behind it. So there's over 4.5 million Americans living with liver disease. So that's almost 2% of the population. And each year, over 50,000 people die from liver disease. So it's actually the 11th leading cause of death. And more than 11,000 patients are currently on the transplant waitlist. So we balance that with about 9,000 life-saving liver transplants that are performed each year. So that's really an incredible number, and it's growing every year, which is great. But clearly, the scale is still lopsided. So there's many, many more people who could benefit from a liver transplant than there are those who receive one. So the question becomes, how do we decide who gets this life-saving treatment? And that is what we will be delving into this morning. So as we're talking, I want everyone to just kind of have in the back of their minds these 4 pillars of medical ethics. So we have autonomy, non-maleficence, beneficence, and justice. And all 4 of those have such a crucial role in the field of liver transplantation. So we'll revisit this slide a few times as we talk this morning. So So for learning objectives, we'll talk about challenges in selection for liver transplantation, including some ethical considerations and disparities that exist. We'll talk through the 6-month rule and many of its limitations. And then finally, we'll talk about standardized approaches to psychosocial assessment and talk about what's currently being done at UW. So the story all begins with this woman pictured here. Her name is Donna Shalala. She was actually a chancellor here at UW from 1988 to 1993, and she later went on to become the Secretary of Health and Human Services under President Clinton. So Donna recognized that there were major inequities in transplant allocation in general, and so she worked to combat them. So before the year 2000, organs were just distributed locally. So there were some states, actually like Wisconsin, that had pretty high donor rates and a relatively lower need for transplant. But then there were other states like California and New York that had much lower donor rates and a higher need for transplants. So you can imagine this created a surplus and a lot of unused organs in some places, and then a shortage and a very dire need for organs in another place. So your ability to receive a transplant was hugely influenced by where you lived. And Donna sought to change this. She helped to create something called the Final Rule, which was passed in the year 2000. So this created a national allocation system for the first time. This could do a lot of good. It could prioritize the sickest patients first, it could avoid wasting organs, and it could minimize the impact of geography. So since then, there's been a few different iterations on this rule. There's been division of the US into 11 different regions, where organs could be preferentially allocated within the region before then being offered more broadly. And then more recently, there's been adoption of this idea of acuity circles, which is a circle of 150 nautical miles around a donor hospital, and that area would get first priority for liver transplant. So all of that helps to minimize the impact of geography on someone's ability to receive a transplant, but still maintain the health of the donor organ by minimizing the time in transit. So clearly, Donna's intentions were rooted in these 4 pillars. She wanted to maximize beneficence in getting these life-saving transplants to patients, but still promote justice, making sure that the organs are getting allocated in a fair manner. So around the same time Donna wrote the Final Rule, physicians at Mayo Clinic developed the MELD score. So interestingly, the MELD score was actually first developed to predict survival after a TIPS procedure. But since then, it's been validated to determine disease severity and the risk of mortality more broadly. So just 2 years later, in 2002, the MELD score was used in organ allocation for the first time. So that could give priority to patients with the highest MELD score, signifying the most severe liver disease. Prior to this time, the main factor in organ allocation was actually time on the wait list. So you can imagine how this did not distribute organs fairly. So someone could have more mild disease that might never culminate in very severe disease, but since they were able to be on the wait list for the longest, they became top priority for transplant. Meanwhile, you could have someone else that presented later in their disease course. They could be in dire need of a transplant, but they would sink to the bottom of the wait list. So as you all know, the MELD score is a formula, and it's based on standardized lab data. So that includes bilirubin, INR, creatinine, and then sodium was added actually pretty recently, just in 2016. So those with the most severe liver disease and the highest MELD scores, regardless of their time on the wait list, could now be prioritized for transplant. That certainly helped to fulfill Donna Shalala's wish. So the MELD score is certainly objective, but it's not perfect. But using it in organ transplant did accomplish a few remarkable things. There was a study led by Dr. Moylan that looked at patients on the transplant waitlist. So after adoption of the MELD score, Black patients became equally as likely as white patients to receive a liver transplant. This was a huge improvement from prior, when Black patients were more likely to die on the waitlist and less likely to receive a liver transplant than white patients. However, I do want to point out a few instances where the MELD score can actually underestimate disease severity and the risk of mortality. So there's certain disease states like HCC and PSC that have more complications and a higher mortality, and that's not necessarily reflected in the MELD score. So there are some exception points that can be applied for, and some of these are very clear, like in the case of HCC, but sometimes the indications can be a little bit more subjective and might vary case to case. And the next group is frail patients. So as you'll recall, creatinine is in that MELD equation. So if you have a lower muscle mass, you'll have a lower creatinine and thus a lower MELD score. And the next group is women. That same study by Dr. Moylan showed that after adoption of the MELD score, women became less likely than men to undergo transplant after being placed on the waitlist. It's estimated that women accrue 1 to 3 fewer MELD points than men with the same estimated GFR. So it makes sense now that there's a push to just include GFR rather than serum creatinine to help improve this disparity. And making matters even worse, if women are given a liver offer, it's more likely to be declined than in men due to a mismatch in size. In an analysis done recently by Drs. Verna and Lai, it's estimated that the deaths of over 800 women could have been prevented in the last decade if they had equal access to liver transplant as men. Dr. Ray Kim and many others are advocating for a MELD 3.0 score, which includes female sex in its equation. So it'll be interesting to see if this takes hold, and personally, I hope it does. So to summarize, although the MELD score does satisfy Donna's criteria that the sickest patients be prioritized, it's still not a totally perfect system. So we just talked about prioritization of patients who are already on the wait list who are now awaiting transplant. But if we take a step back and look at who is put on the wait list in the first place, we can see what a vital decision this is. So this study done at UW, led by Dr. Musto, looked at outcomes in patients with severe alcohol-associated liver disease and recent drinking. So inclusion criteria were having a diagnosis of ALD, having a MELD score over 25, and having less than 90 days of abstinence from alcohol. So on the x-axis, we have days from liver transplant evaluation, and on the y, we have the probability of survival. So clearly, those in the red line who underwent transplant had a higher probability of survival than those who didn't, who are depicted in the blue dotted line. So deciding who gets put on the wait list and thus who has even a chance at a potentially life-saving liver transplant is a life or death decision. So we'll spend the next few minutes talking about alcohol-associated liver disease, or ALD, and what makes that different from other forms of liver disease when it comes to the transplant evaluation, and specifically the psychosocial assessment. So I'd like everyone to take a minute and recall a patient that you've taken care of with ALD. So this could be on wards or in clinic, and recall your interaction with the patient. So the things that they said or they did, or maybe what you said or you did in that encounter. And how did you feel towards this person? And now think to yourself, would you have felt differently if you were seeing them for another form of liver disease, like NASH or alpha-1 antitrypsin deficiency? And the reason ALD is different boils down to stigma, which comes in many different levels. Stigma hugely impacts selection of ALD patients. So the first form of stigma that we'll talk about is self-stigma or shame. Many patients with ALD feel like, I did this to myself, I'm not worthy of medical care, and I'm definitely not worthy of this precious organ. As Dr. Meyer eloquently stated last week, shame is the most potent driver of human behavior. If these patients had negative experiences in the past with the medical system, they might be less likely to present to care or present much later in their disease course when their liver disease is already decompensated. They clearly feel the effects of the next circle, which is social stigma. There's a pervasive negative connotation in our society around patients with alcohol use disorder, which consciously or subconsciously can influence physicians' referrals to transplant centers and even the decisions that are made at liver selection committees. Social stigma has a direct influence on structural stigma, which is laws and policies that impact ALD patients being listed for transplant, such as the 6-month rule that we'll talk about in a minute. Together, these various forms of stigma can impact referral and selection of ALD patients, preventing them from even having a chance at a life-saving transplant. Another form of structural stigma is the lack of transparent policies surrounding selection for transplant. So each transplant center makes its own policies surrounding alcohol use, and these policies are not publicly available to patients. So the y-axis is the number of transplant centers in the US, up to 141. So all 141 centers had a website, but just 50% mentioned any eligibility criteria at all. Only 17% of websites had any discussion of alcohol use, and only 2% clearly stated that they had a 6-month abstinence rule, even though we know in practice the number is much higher than that. So this secrecy erodes trust between patients and the medical community. If we were to develop clear and written policies, that could help not only committee members in their decision-making, but it could also help promote trust and transparency with patients and their families. And all of this is so important since ALD is now the most common indication for liver transplant listing in the US. So this graphic looks at the number of waitlist registrants over the past several years. So you can see ALD in green there narrowly beats out NASH as being the top indication for liver transplant listing. And both of those are significantly higher than hepatitis C, which is pictured in red, thanks to some great new treatments. A unique concern, though, in this population is that returning to alcohol use after transplant can have detrimental effects to the graft. So work done at UW by Dr. Rice is shown here. So we have years since transplant on the X and proportion of graft failure-free patients on the Y. So being lower on the chart means more graft failure. So those without continuous heavy alcohol use are plotted on the black line, and those with continuous heavy use are on the dotted line. Clearly, those with continuous heavy alcohol use have more graft failure than those who do not. Although I do want to point out this difference isn't seen until a few years after transplant. So this begs the question, how do we select patients who are least likely to use alcohol after transplant and thus be least likely to jeopardize their allograft in the years following transplant? There's some really important ethical considerations in what we just discussed. If women had the same opportunity for liver transplantation as men, 800 lives could have been saved in the last 10 years. To me, that does not sound like a just system. And does stigma stand in the way of providing beneficence for ALD patients? To help make this process a little more fair, national organizations like the AASLD have put forth recommendations for standardized evaluations. Again, though, I want to highlight that these are broad recommendations and each transplant center can decide their own exact processes. So there's a frailty assessment and overall nutrition screening. There's a cardiac evaluation. So oftentimes this will be with an echocardiogram, sometimes a cardiac cath or a coronary CT. There's bone density testing, hepatic imaging, which can help with surgical planning, as well as extensive lab testing to look for other etiologies of liver disease. There's a psychosocial evaluation, which can vary greatly between institutions. There's a neurocognitive evaluation, and that can help differentiate neurocognitive impairment from hepatic encephalopathy. A dental assessment, evaluation for one of several different liver-lung syndromes, which has a big impact on surgical morbidity and mortality, a renal assessment, and then full infection screening and cancer screening. In patients with ALD, the psychosocial assessment has such an outsized effect on transplant listing, much more than in patients with etiologies other than ALD. And we do have some data to back this up towards the end of the talk. The list of contraindications to transplantation are also left up to some interpretation by each transplant center. So this list of contraindications is evolving as surgical techniques are improving. And ultimately, it becomes a judgment call by the transplant team if the patient has the ability to survive surgery and become well again. And in terms of the psychosocial assessment, and specifically on the bottom there, that question of social support, national organizations state that patients should have adequate social and caregiver support to provide the necessary assistance both while waitlisted and until independently functioning in the post-operative period. So you can see how this is pretty wide open for interpretation by each transplant center. So a very interesting study led by Dr. Volk in 2011 looked qualitatively at the transplant selection process. This was a pretty cool study. So he went to 4 different transplant centers and he studied 63 different transplant selection committee meetings. He concluded overall, he thought the committees were well-intentioned, but he did think that decisions could be improved if there was more explicit written policies. So I highlighted a couple excerpts from the paper that I thought were especially interesting. So the first one. There was a strong correlation between psychosocial barriers to transplantation and socioeconomic status. And the next. Although we found no evidence that committees overtly judged candidacy on the basis of social worth, members would include such factors as education, intelligence, and financial resources in their assessments of a patient's ability to carry out necessary treatment plans. And the disparities that he noted have also been borne out in data. Black patients have lower listing rates relative to overall deaths from end-stage liver disease, suggesting that fewer Black patients are being put on the wait list. And although we talked earlier about how the MELD score can help equalize disparities once patients are already on the wait list, the disparity really exists a step before this process in terms of referral for evaluation and listing. Also, the further a patient lives away from a transplant center, the less likely they are to be put on a wait list or undergo transplant, and the more likely they are to die. This directly goes against Donna Shalala's wish that geography should not play a factor in someone's ability to undergo transplant. Poor patients also face disparities. Being on public insurance like Medicaid is an independent predictor of denial for transplant listing. And it's not that all of these patients are just inherently worse transplant candidates solely based on their race, zip code, or their income. But rather there are pre-existing inequities that are already in place, and our referral and selection processes can perpetuate these. So just focusing on how organs are allocated among patients already on the waitlist is missing a huge piece of the disparity that exists, which is prior to transplant listing. I'm sure many of you have heard about structural or social determinants of health, which in simple terms is that where someone spends their time can have a huge impact on health outcomes. So this is talking about things like safe housing, discrimination and violence, education and job opportunities, and access to food. Dr. Ardeshna presented several weeks ago at DDW the first population-based study looking at social determinants of health and their impact on liver transplant listing among patients with decompensated cirrhosis. So their national database collected information about 4 different social determinants of health. So low income, so being in the first or second income quartile, being on Medicare or Medicaid for insurance, self-identification as African American or Hispanic, and admission to a rural hospital. They found that 90% of patients with decompensated cirrhosis have at least one of those factors, and that the more factors that were present, the lower the liver transplant listing rate. So having 2 or 4 factors reduce the chances of undergoing a liver transplant by 60 and 90%. So clearly the geography and thus the community where someone lives still has a large impact on their ability to undergo transplantation. The fact that your income, race and ethnicity, and zip code have such an impact on your ability to undergo transplant certainly goes against the principle of justice, and it's harming large numbers of people. So to summarize what we've talked about so far, liver transplantation involves rationing medical care through subjective decisions with criteria that are open for interpretation and that have life and death repercussions. So how can we make this process more fair? We can't fix the entire system, but we can focus on selection practices from patients who have already been referred. And one way to do this is by using standardized psychosocial assessments to ensure that all patients being considered for transplant are being scrutinized in the same way. So the first of these standardized criteria was the 6-month rule, used in patients with ALD, where a patient would be required to be abstinent from alcohol for 6 months prior to liver transplant listing. So although this was never officially adopted by any national organization like UNOS or OPTN, it was pretty widespread in clinical practice. So the 6-month rule was rooted in really good intentions. It gave time for some patients to have spontaneous recovery of their liver function, which could prevent the need for transplant in some patients who would improve regardless of getting a transplant or not. So this could free up some organs to other people who needed them. However, there are several issues with this rule. The first is that if a patient had even one slip and admitted to it, they would have to restart the entire 6 months. This put patients in an impossible and frankly an unethical situation. If they had a slip, no matter how small, should they admit it and ask for help to get them back on track? Or should they hide it from their medical team to stay on the wait list and maintain their chance at getting a life-saving transplant? This incentivized patients to be evasive about their alcohol use and perpetuated mistrust between patients and the medical community. Not to mention, it promoted a great deal of shame among potential recipients. The reality is that spontaneous recovery, if it happens quite quickly. So this figure is from the same UW study mentioned earlier, and it looks at the subset of patients who ultimately recovered their liver function. And it looks at the proportion of patients with high MELD scores each week after liver transplant evaluation. So you can see, even just in the first week, patients start to recover. And by week 4, almost nobody who ultimately recovered still had a very elevated MELD score. So we can generally have a pretty good sense if a patient will ultimately recover just within the first few weeks, much less than 6 months. Another problem with this is that many patients simply do not have 6 months to wait. Dr. Matherin led a European prospective pilot study to evaluate transplantation for acute alcohol-associated hepatitis. So this Kaplan-Meier curve plots months since transplant evaluation on the X versus percent survival on the Y. And it looks at those who underwent transplant on the top line in gray versus matched controls who did not undergo transplant in the bottom black line. Again, clearly a survival benefit in those who undergo transplantation. And you can see that first vertical dotted line is 6 months. The vast majority of deaths happen in this time frame. So transplant is life-saving, particularly in the first 6 months. The proof of concept of using transplantation for acute alcohol-associated hepatitis was confirmed by this American retrospective study. So the Accelerate Consortium included 12 different transplant centers, including UW, who performed early transplant without a set length of preceding sobriety. Survival at 1 and 3 years were outstanding, 94% at 1 year and 84% at 3 years. Relatively few patients returned to sustained alcohol use, so just 10% at 1 year and 17% at 3 years. It confirmed the mortality without transplant was about 70% at 6 months. And looking back at this figure we saw earlier, I want to highlight one important point. Even in patients who don't undergo transplant and who do ultimately recover, only 20% of those regain a compensated state, meaning they're not on medications for ascites or hepatic encephalopathy. So even if they technically recover, their health is probably not fully restored. There's so few areas in medicine with such a drastic improvement in morbidity and mortality with a given treatment. And there's evidence that 6 months is not even a very good predictor of future drinking. So this study, led by Dr. DiMartini, looked at a group of patients, all of whom had 6 months of sobriety prior to transplant. And there were relapses after transplant, and they occurred in several different patterns. So here we see the log number of drinks plotted against days after liver transplant discharge. So there were a few distinct patterns. In the green, we have someone who had a prompt but a pretty short slip who later regained sobriety. The patient in yellow also had a pretty prompt but more of a continuous relapse. And someone in blue didn't have significant alcohol use until many years after transplant. So clearly, alcohol relapse can occur even after 6 months of sobriety prior to liver transplant. And these slips and relapses are not one size fits all. We could clearly benefit from tools that can better predict the risk of relapse rather than just rely on some arbitrary set time period prior to transplant. We know that alcohol use disorder is a lifelong disease. Sustained alcohol use can lead to alcohol-associated liver disease, oftentimes with the sentinel episode of alcohol-associated hepatitis prior to transplant. And surveillance for alcohol use is not only important in the days leading up to transplant, but also after transplant. And surveillance that is standardized across all patients allows us to identify slips or even clinically significant relapses. And this is important so that we can offer support and medications to get the patient back on track and hopefully prevent clinical sequelae, including graft injury or dreaded graft loss. Ensuring that all patients are being scrutinized in the same way is a key tenet of standardized psychosocial assessment. So rather than just relying on a fixed period of alcohol abstinence, this can give a more holistic assessment of each individual patient's risk. So we've already talked about how this can increase trust and transparency between patients and the medical community. And it allows transplant centers to be more forthcoming with the public about their policies. It also promotes equity, ensuring that everyone is being given the same consideration. It limits judgments on social worth, ensuring that some patients might not have an unfair advantage or disadvantage in transplant listing. Standardized policies also decrease frustration among liver selection committees, who often state that selection meetings can be frustrating or even sometimes distressing, feeling like decisions are unfair or inconsistent. And finally, as we just mentioned, these assessments can identify high-risk areas in a patient's psychosocial profile that allows the team to allocate resources towards improving. So together, these benefits promote beneficence and could potentially expand the pool of patients who are able to receive a liver transplant, while still balancing justice, making sure the organs are being allocated fairly. So we know standardizing psychosocial assessments has many, many benefits. So what are we doing here at UW? For several years, the transplant team here has used the Stanford Integrated Psychosocial Assessment for Transplant, or SIPAT. So this was developed by Dr. Maldonado out of, you guessed it, Stanford University in 2012. So this information is all stored in our electronic medical record, and each of the 4 domains are given a numeric score with clear descriptions of each. So this is a semi-structured interview. It takes about 45 minutes and is completed by a social worker on our team. So again, there's 4 domains. The first one is readiness, which includes both the patient and their caregiver's knowledge and understanding of their medical illness, as well as the overall transplant process, including risks and benefits. It looks at the patient's willingness and desire to undergo transplant and their prior treatment adherence and lifestyle factors like diet and exercise. The next domain is social support. So this looks at availability of social support, which could be family members, significant others, friends, or even neighbors, and that there's a backup support for support if needed. As well as availability, it also looks at the functionality of the social support. So are the support people committed to learning about the patient's disease and their caregiving role? And are they actively engaged with treatment? It also looks at a patient's living space. So is this stable housing or is it more transient or tenuous? The third domain is substance use. So this includes the impact of alcohol use on the patient's life, completion of the full audit score, and also addresses any other substance use, including nicotine use. And the final domain is psychological stability and psychopathology. So this looks at comorbid psychiatric disease with tools like the PHQ-9 or the GAD-7 to be used as needed. It also looks at comorbid personality disorders and any history of deceptive behaviors. So the scores from each subscore and domain are all tallied up, and the patient is given an overall risk score. So 0 to 20 is considered a low risk candidate, whereas greater than 40 is a high risk candidate. So importantly, there's no score cutoff above which transplant is denied. But higher scores can be kind of a signpost to proceed with caution, with things like more frequent alcohol biomarker testing, counseling, referral to psychiatric care and treatment, and social work support, rather than just a stop sign to deny transplant based on any one single factor. Very importantly, high-risk areas identified can allow the transplant team an opportunity to intervene and help the patient. Our team's research on the impact of psychosocial assessment on the selection process for patients with ALD was recently published in Liver Transplantation. And I wanted to give a big thanks to Maureen Garvey and Christina Lightbourne for all of their help with this, among many other people on the team. So our research group looked at patients who underwent liver transplant evaluation and who had a complete SIPAT assessment between June 2018 and December 2019. So out of the 358 patients, 187 were approved for transplant listing and 171 were declined or deferred. So now I'll present some of our data from this study. So this top table looks at MELD scores. So if you look horizontally, you'll see ALD patients had similar MELD scores whether they were approved or not, about 25. Non-ALD patients, the MELD scores were also pretty similar, about 17 to 18. So there was a similar MELD score between those approved or not approved within each disease category. However, if you look vertically, you'll see patients with ALD had significantly higher MELD scores than non-ALD patients. So as a whole, ALD patients were a sicker population given their higher MELD scores. And now looking at this bottom table, we see the SIPAT scores. So remember, a higher SIPAT score indicates more psychosocial vulnerability. So again, looking horizontally, ALD patients approved for transplant had a lower SIPAT score than those not approved, meaning those who were approved were less psychosocially vulnerable than those denied. There was also a difference among the non-ALD patients, but it wasn't quite as pronounced. So again, looking vertically, SIPAT scores in the ALD group were higher. It's also important to note the SIPAT scores in the ALD group were higher in all 4 domains, not just the substance use domain. So although ALD patients have more psychosocial vulnerability, we are selecting those with the least among that group. So we concluded that ALD patients had higher SIPAT scores, so more psychosocial vulnerability, and higher MELD scores, so they were sicker compared to non-ALD patients. The MELD score was similar between the ALD patients who were approved and not approved, suggesting that SIPAT, or their psychosocial status, was the main determinant of transplant listing rather than the severity of illness. And although we do transplant vulnerable ALD patients with significant psychosocial injury, they're still less likely to be approved than non-ALD patients. So we concluded that even though ALD patients are sicker, the psychosocial assessment is the principal determinant of selection. So where does this leave us? We wanted to study if the greater vulnerability of ALD patients on the waiting list translated to worse short-term outcomes. So specifically, we looked at a couple transplant outcomes I'll talk about, mortality and resumption of alcohol use. And we have 3 years of unpublished follow-up data, which I'll show now. So we looked at that same cohort of patients from the prior study and followed them through October of last year for a median follow-up of 2.5 years. So within that original cohort of 358, 187 were approved for transplant listing and are included in our follow-up study. So out of those, 82 had ALD and 105 had not. So we looked at dates of transplant, retransplant, death, and liver biopsy data to see if there was any evidence of rejection. We also looked at alcohol use, and we did that through looking at biomarkers, including ethanol, urine ethylglucuronide, and PEth. And we looked through hepatology notes to see if the patient disclosed any alcohol use. And Faye Osman is on the study, and she helped tremendously with our statistical analysis. So here we look at major transplantation outcomes between ALD and non-ALD patients. And the outcomes we studied were rates of death, transplantation, rejection, and retransplantation. None of the p-values were significantly different between the ALD and non-ALD groups. So we concluded that there were no significant differences in major outcomes between the two groups after being placed on the wait list. Here we look at alcohol biomarker data of all listed patients. Interestingly, we saw a return to alcohol use in both groups, 12% in the ALD group and 5% in the non-ALD group. So overall, pretty small percent in each group. As a side note, we did look a little bit more to see about alcohol use patterns, and we only observed heavy or harmful use in the ALD group, which we classified as more than 14 drinks per week for men or 7 for women, or any single PEth value greater than 112. So biomarkers were more likely to be checked in the ALD group at least once, both pre and post-transplant, but they weren't checked consistently. So we concluded that although we saw alcohol use in both groups, heavy use was only seen in the ALD group. And biomarkers were more likely to be checked in ALD patients, but were not checked consistently. And the next 2 slides look at predictors of different outcomes. So you can think of a hazard ratio of less than 1 as being a protective effect. So this slide looks at predictors of mortality among all listed patients. So you can see out of ALD diagnosis, PSI-PAT score, MELD score, transplantation, and a return to alcohol use, the only one with a significant p-value and thus a protective effect against mortality was transplantation. The rest did not significantly impact mortality. This table looks at predictors of returning to alcohol use among all listed patients. Again, small numbers of patients had any alcohol use after listing, just 10 in the ALD group and 6 in the non-ALD. And we found that PSI-PAT score did predict alcohol use. So we concluded that ALD patients had similar rates of a lot of important outcomes, including mortality and rejection, as non-ALD patients, despite having higher MELD scores and PSI-PAT scores. So similar outcomes despite being sicker and having more psychosocial vulnerability. High PSI-PAT scores were predictive of alcohol use after placement on the waitlist. But in the short term, at least during our follow-up period of 2 to 3 years, alcohol use was not associated with mortality. So our next steps are to publish that study, hopefully very soon. We'd also like to continue to follow our cohort to look at longer term outcomes to see if those might differ from our short and medium term outcomes. And we'd also like to examine the role that social determinants of health might have on our selection process and understand its relationship with the PSI-PAT score. So we've talked about a lot this morning. So to summarize the main points I hope that you can take away from this lecture. There are many challenges in liver transplant selection. There's ethical considerations whenever we're dealing with rationing medical care, especially when the criteria to make decisions can be ambiguous, can differ across centers, and has life and death repercussions. We talked about disparities that exist in transplant, and there are many, including sex, diagnosis, race and ethnicity, income, and geography. And the disparities exist both at actual organ allocation once patients are already on the wait list, as well as the step prior, which is the processes of referral and selection for the wait list. Finally, standardized psychosocial assessments can be one step in combating these disparities. If all patients who are referred for evaluation are being scrutinized in the same way, that can limit social worth judgments, increase trust and transparency between patients and the medical community. And very importantly, it can allow the transplant team an opportunity to intervene and help the patient with any identified high-risk areas. So if you find yourself in a similar situation that I was in, not really knowing what was going on behind the scenes to arrive at these major decisions, I hope this talk has demystified at least some aspects of that process. So thank you all so much for being here this morning. I have many thanks to give. I want to start with a huge thank you to Dr. Michael Lucy. You have been an incredible mentor to me for the past 4 years. And really, I can't thank you enough for all of your support and guidance. I'd also like to thank the whole SciPat research group. It has been such an honor to be part of this research, and I'm really looking forward to continuing our important work. Next, I'd like to thank the whole residency team. So Andy, you have been an incredible program director this year. It's incredible to think about how much the program has changed just in the past year. And I'm really excited to see all of the changes that are in store for next year. Dr. Andrea Schnell, you've been an incredible chief mentor to me this year, so thank you for everything. Dr. Jeremy Smith, thank you for your guidance and especially helping me to prepare this talk. And the whole education team, you guys are all awesome. It's been really great to work with you all this year. Dr. Schnapp, thank you for your mentorship to all of the chiefs throughout the year. We really appreciate it and the opportunity to present today at Grand Rounds. And last but not least, our incredible residents. It truly has been one of the biggest honors of my life to be one of your chief residents this year. I've learned so much from you all, and I hope I have taught you even just the tiniest sliver of what you all have taught me. And then on a personal level, a huge thank you to my co-chiefs. We've affectionately named ourselves Snell, Scott, Nimrod, Emily, and me. I could not have gotten through this year without you guys. So I'll really miss this office, our rambunctious office on the 5th floor. And then my amazing family, including my husband, Tom. The picture on the top right is match day at Tulane in 2018, when we found out that we couples matched here at Wisconsin. And to end, everyone knows, obviously, no lecture of mine would be complete without a picture of Tibby, my Bernese mountain dog. So thank you again, everyone, so much for your time this morning.
Wonderful. Thanks, Lindsay, for a really excellent talk, impactful, important, and I think a great reflection on the challenges of this work and the importance of sort of critical reflection of our own processes and biases. So as people have questions, put them into the chat and I can feed them to Lindsay. I'll start with a question of my own, which obviously I'm a primary care physician. I think you highlighted really nicely in the talk, sort of like the power of shame when it relates to alcohol and the incredible risk that people have of relapse in alcohol use disorder. So obviously combining those things, sort of screening post-transplant is incredibly important. Now, I'm curious, are there like official recommendations or what guidance do you have for us about how we should sort of tackle that screening challenge post-transplant?
It's a great question. I mean, I think what currently is done throughout the whole country is, you know, if someone's kind of nebulously deemed to be high risk, they may be getting screened more frequently, although maybe not standardized. And I think that may capture a good amount of people with really, really significant relapses, but it's missing a huge chunk of people. So I think for me, what would be most important or impactful would be, again, to kind of standardize the process. And that might vary institution to institution, but I think it would be a good time to include that in kind of the informed consent process for transplant, to say all patients, regardless, you know, if they have autoimmune hepatitis or NASH or any type of liver disease, to just standardize that and say all patients, we get PET testing, which can be positive for up to a month at, you know, intervals 1 month, 3 months, 6 months, whatever that is, and just kind of have that be standardized, because then you can tell patients up front, this is what we do and this is how we do it. And I think your question about shame is really good. I mean, you know, obviously that would be a huge part if it is discovered someone has alcohol use. And I think having that be part of the informed consent process, that they know that they're not being singled out and that we do this for everyone, and just really highlighting that over the many years after transplant, like helping people get on medications and get into treatment can really impact their long-term outcomes over many years. So I think to answer it succinctly, having a standardized policy, doing it the same for everyone, and then really emphasizing that it's to get them into treatment to help them. But it's hard.
Great, thank you. So questions starting to flow in, so I'll ask you some of those from one of your co-chiefs. Hopefully not an impossible question to answer. So fantastic presentation from Scott. Does UW have standardized or specialized resources initiated for transplant candidates to address the most at-risk domains of their personal XIPAT score?
That's a great question. And we have an amazing transplant team here. We have dedicated social workers, including Maureen Garvey, who I think is on this call. And they really do so much. And so I think it's another really good point of the benefit of referring someone to a transplant center. Like if you were out in the community and you saw this, just like all of the benefits that a transplant center can have in terms of these intensive resources by social workers and counselors. So I think, it really becomes kind of an individualized approach based on the high risk areas that we have, but certainly, we do have dedicated resources from the transplant team.
Great. So from the chat, Dr. Morsetter asked, given that the higher risk patient did not pan out to have worse outcomes, are we transplanting the right people? Are we missing a group who are removed unnecessarily due to high scores?
That is a very, very interesting question. And I think, we just have data from 2 to 3 years. And so we wonder, that graphic from Dr. Rice, like the split sometimes doesn't happen for many, many years after transplant. So I think it may be a little bit too early to tell that just based on 2 to 3 years of data, but that's certainly why we want to continue to follow the cohort. But it could be possible that, we could change in the future, kind of the criteria that we're using. So that's a great question and a great thought.
Great. From Farah, should OPN standardize the process across the country?
What was it? Should we standardize the process?
Should OPN standardize the process across the country?
That'd be great. That'd be kind of the dream, I think. And, Donna's wish that geography really shouldn't be playing a part, and, being in certain states really should not impact your ability to get a transplant, and going to one transplant center over the other shouldn't cause you to be more stringently evaluated or less stringently evaluated. So I think coming up with those policies in the long term, once we have better data on really what does impact the outcomes, I think that would be the goal. That would be great.
Right. From Aaron Lowry from the lung transplant team. Fantastic talk. We also use XIPAT, but notice that it really penalizes patients for past substance use, even if the patient has recovered and went through proper pathways for recovery, and that is no longer an issue. Shouldn't prolonged abstinence and recovery be rewarded in the XIPAT? And do you think an updated XIPAT that accounts for that might be warranted?
That's a great thought. Certainly, I think, and it's interesting to hear in solid organ transplants other than liver, which, obviously alcohol and substance uses can be so highly implicated, but yeah, that's a great point. I wonder about that. And that was from 2012. So we're coming up on 10 years. So maybe time for a revamp of that. Great.
Wow. And then in the chat, I won't read it all, but I think a comment that I think really highlights the importance of this work about, a patient from Green Bay who was repeatedly denied a liver transplant, just really as a function of living far away and challenges in accessing the system, and really sad and awful outcome for the patient. So I think just a further emphasis of the importance of thoughtful allocation of organs and not letting bias get in the way.
Yeah, I think that's a great point. Part of me was surprised to hear that geography, the further you live from a transplant center, increases your risk of mortality, but it does make sense. They just have less access to all of these resources available at the transplant center, but I certainly wish that weren't the case, especially, I think we see that a lot in a state like Wisconsin that has such a large rural population. So I hope that will change.
Right, and then not to editorialize, but I think having been at a previous institution in New York before, I think kind of the previous sort of like region system has huge flaws where like all of our patients in New York were dual listed or tri-listed in different regions because they had access to multiple like transplant centers within like an hour of their home. And so it was incredibly common that patients were listed at Sinai and at Penn because they could live between those two and have dual listings. And so a lot of inequities related to rural health. That's, I think, has been a theme of multiple recent outstanding grand rounds.
Absolutely.
So a question from Brad Astor. Have you investigated medication adherence or other potential pathways from low social support to clinical outcomes?
That's a really, really good question. Yeah, it's a really good question too. And I think it's something that I've grappled with the question of alcohol relapse, because that can be so destabilizing in so many arenas of life that it's like, what's the alcohol relapse and what's you not taking your immunosuppression? So we haven't personally studied that, but I think that is a really good point, especially if we're able to get, lab data on adherence potentially to different immunosuppressing medications. So that'd be a good study question.
Great. So the lung to liver transplant conversation continues. So another question. So agree with more transparency and selection policies from individual programs is long overdue. However, do you think if individual programs publish their selection policies, this would corner transplant teams to stick to these policies and not have flexibility to bend the policies in individual cases?
It's really interesting. I mean, I think that brings up this ethical conundrum that we have, and it's like balancing how transparent are you, and then how much are you following what you're saying. So I think, there's certainly cases where you would want to bend the rules, but I guess then the corollary to that is it fair or just to be bending the rules for certain patients? And if so, who are those patients that you're bending the rules for? And do they have some type of like inherent advantage that potentially you would not be bending the rules for some more disadvantaged population? So I think it's really hard, and I certainly don't know the answer to that, but I think it brings up a really good point about just how ethically hard some of these decisions are.
Yeah, I think, it's just so challenging that it's like in a system with no structure, like rigidity and having sort of really firm guardrails is really appealing until then you live in that system and you sort of miss the opportunity to kind of bend those rules to advocate. But I think it's been pointed out by you, by chat, by questions, how we sort of blind ourselves to biases seems like an impossible task, and how we create a system that is equitable across all geographies, patient populations is incredibly hard.
It's hard. Yeah, it's really hard. I can imagine being on the transplant selection committee. You want to do good for your patients, and it can just put you in really hard positions. So
wonderful. I think we've exhausted all of our many questions. We are right at the end of time. So maybe we'll close grand rounds there. So I want to thank Lindsay again for an outstanding presentation, and thank all 4 of our chief residents for outstanding presentations, for outstanding service to the program, to the department, to the institution. We will greatly miss you, are so incredibly proud of you, of all of our chief residents and all you've done for us. So thank you. Thank you everyone for being here, and happy Friday.
thank you.